And good morning. Welcome to Duke Spine Institute. Our patient travels here from Canada, and it is Thursday, May 15, 2025. And for those of you who are watching, you can obviously see he's had an incision done. He's had back surgery already, and he's had what's called a microdiscectomy or discectomy. You can see the incision is actually a lot bigger than it should be, but it's almost 3.5 centimeters, right, which equates to about an inch and a half, okay? The incision today will not be 3.5 centimeters. It will be 7 millimeters. So basically, there you go. He had one disc operated on. And by the way, do you know why he's here? He's here because this surgery doesn't work. Okay, it doesn't work. We're going to be fixing 3 discs, 3 of them from the left side because he has left leg symptoms, and 1 of them from the right side. So we're going to do 1, 2, 3, 4 disc areas that have to be fixed. We're also going to do a piriformis release later. All right, I'm going to get started by first planting the needles through the skin and into the tear. This needle does no damage whatsoever. It just punctures the skin. And then I'm going to use the needle to place a guide wire, a dilator, and a tube that we do the whole surgery through. In the meantime, Henry is going to show you a video on the 30 different causes of back pain. This patient has 4. He has 3 discs that are causing his back pain and a torn muscle in the right buttock. 1, 2, 3, 4, 3 discs, 1 muscle. We're going to fix all 4 today. The average patient has 4, so he's par for the course, okay? Some patients have up to 14. We've seen 14 causes of back pain. So Henry, without further ado, would you please share with our audience, Dr. B, he's moving a little bit, the 30 causes of back pain. I'm Dr. R. Dugmajian with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The 4th most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Machen. Thanks for joining us. And welcome back. So from our video, those of you watching can see that there are 30 distinct causes of back pain. 30. Okay? This patient has had lower back pain for how long?
3 years.
No, it's been longer than that, but we'll just put 3 years. It's been very bad for 3 years, but he's had it much longer. There are 30 different causes from the video, and the most common is disc. Disc represents 85% of all chronic back pain. 85%, the disc is the number one cause. The second most common cause is facet, which represents around, well, it's 9%, but we'll just make it easy at 10%. And then you have the, what I believe is now the piriformis. That's a piriformis muscle tear, and that's going to be around 3% as the primary cause. And the final cause is the SI joint, which is around 2%. Now, you may say, Dr. Duke, what about fractures of the spine? Yes, fractures do occur and they do cause chronic pain, but it is less than 1% fractures. And these are mostly compression fractures of the vertebral body, okay? But by far, the disc is the number one cause. This was discovered at Duke Spine Institute. We studied 5,000 patients. 5,000 patients with chronic lower back pain, and we analyzed what caused their pain. What's the main cause? The number one cause, the primary cause. And it turns out that most patients have more than one cause, but the vast majority of the patients, the primary cause was disc. This patient has 3 discs causing his back pain. 1, 2, and 3. Now, he had microdiscectomy done in Canada or somewhere else, and it just did not work. And so he's here now at Duke Spine to have proper treatment to get rid of his back pain. All right, I got to place one more needle. And while I place this last needle, I'll talk to you. We're doing bilateral 4-5, correct? Correct. I'm going to talk to you briefly about the different causes of back pain, Sean. And I want you to understand that these 30 causes of back pain can now be cured. AP? Can now be cured. We can cure them here at Duke Spine. But you cannot get the back pain cured everywhere. Only really at Duke Spine. We're the only place in the world that can cure your back pain. All right, that 5-1 needle is, as always, deflected by the facet, and I'm not happy about it, but I think we're good enough to do to get into the disc. So disc is the #1 cause. Facet is #2. Piriformis #3. Our patient is actually awake because we wanted to verify the source of back pain. By the way, for those of you watching, let's get that ruler out. This is the blood we've lost. This is a nosebleed worth of blood. Nosebleed. That's all we're going to lose. Here's your incision right there. Again, it's around 8 millimeters, 7 or 8 millimeters. Not like the other one, okay, that didn't work, the microdiscectomy. Okay, are you comfortable?
He said yes.
Are you having any pain?
No.
He came from far away. He traveled from another country, from Canada. Are you comfortable now? All right, good. How bad is that pain on a scale of 1 to 10? How high does it go? What's the highest? 10. Is that where you get your back pain? Yes. All right, that's the first disc we tested, so we're going to fix that for you. That will be gone. 10 out of 10 back pain, concordant at L3-4. Folks, we just verified with the only test in the world that you can verify whether a disc is causing the back pain. It's called a disc evocative discogram. We just did it, and he said it's 10 out of 10, and it's concordant at L3-4, okay? You can see it on the x-ray. There's a gigantic tear in the back of the disc. That's what is causing his pain. We're going to fix that tear with the Duke laser disc repair. It's the only surgery in the world that cures the back pain from a disc injury. Remember, discs make up 85%. Are you having any pain now? Yes, a little bit? Is it better? Yes. All right, good. How bad is that on a scale of 1 to 10? What's the highest? 8. 8 is the highest? All right. So L4-5 is an 8 out of 10. Is that where you get your back pain? Concordant. All right. L4-5 is 8 out of 10. Look at the size of the tear. Go to the x-ray, Henry. Look at how big the tear is. It's massive. Jordan is circling the tear. Circle the tear, Jordan. Circle. That's not all the tear. It's all the way back. Even further. Back towards the back. That's the front. Yeah. Circle. There you go. That's the tear. It's humongous. And a black dye in the tear, that's what we have to fix. Are you better now? All right. I apologize. We're going to put you to sleep in a moment. How bad is that on a scale of 1 to 10? 10. Is that where you get your back pain? All right. We just found the last disc, L3-S1, is a 10 out of 10, concordant. So this is great news. We're going to put you to sleep. Can you count out loud from 1 to 100? I want to do 5-1 last.
Okay. You want to start with 3-4?
Yeah. So folks, we just tested the 3 discs that I thought were causing his back pain based on the Duke spine exam. The Duke spine exam is a special examination done here at Duke Spine Institute and only at Duke Spine Institute. The Duke spine exam tells us where the patient's back pain is coming from. Now we do this exam on the internet. We do it over Zoom, telemedicine, video conferencing, and we can accurately diagnose your back pain with a video conference from one of our Duke Spine Institute staff. All right, we're going to go and repair these 3 discs. And look at the dye coming out the other side, by the way, at L4-5. You see this, Henry? It just squirted out.
Yes, we do.
You see that? It just literally squirted out of there. So we did not inject blue dye here. We injected it here, but it went across the disc to the other side and out the other needle. Pretty cool. We're going to start with fixing L3-4 on the left. Any questions?
We have a comment and a question. This comment is coming from Smallville 1219 on YouTube.
None.
saying, "Hi Doc, it's Christian. I had the MRI review last week.
Oh, hi, Christian.
So happy I found you guys and can't wait to see you guys in person. Looking forward to getting my life back. I've been telling a bunch of friends and family and clients that come to my animal hospital who have all disc problems, and when I tell them about what type of surgery you offer, they are amazed."
Thank you, Christian. And it's wonderful to have you here. I do remember you, and I hope we're able to fix you. I know we can fix you if you come here. I just hope you're able to come here and get fixed. That said, thank you for joining us. So folks, look at the x-ray. We are with the dilator at the back of the L3-4 disc. And we're about to enter. I get this question a lot. Dr. Duke, when you put the dilator, I need blood pressure down. When you put the dilator in, aren't you damaging the disc? The answer is no. We are entering the disc through the tear that's already there in the back of the disc. We're actually going right through the herniation, and we're pushing the herniation back into the disc. We're going to take the herniation out right after we push it in. This is called the inside-out technique. There are two ways to do endoscopic endoscopic transforaminal surgery in the lumbar, and one is called inside out, the other one's called outside in. And the inside out technique that I use, I learned from Dr. Young, Anthony Young out of Phoenix. He was really a big advocate for this technique. And Dr. Young basically explained that this technique is the safer of the two. By using the inside out technique, we can make sure that we don't harm anything. All right, look at that, guys. The dilator has literally pushed itself out of the disc because the disc has so much pressure inside from inflammation. Did you see that? That's incredible. So there's so much inflammation in this disc, which is causing us pain, by the way, that it literally pushed out the dilator. We see that quite often with severely inflamed discs, and that's what this is. All right, we're inside the tear right now. You can see, Jordan will show you on the x-ray, the tube. That's this 7-millimeter tube. And we're going to use this tube, it's like a metal straw, to get inside the tear and remove the herniation and debride the tear. We're not doing a discectomy. This is not a discectomy. We're not taking bones out of your spine like other surgeons do. We're just cleaning the tear and getting rid of the herniation that's stuck in the tear causing the back pain. Again, we were the first to discover this at Duke Spine. I discovered it 19 years ago in 2006, and I've been doing this surgery since 2006, curing people's back pain. All right, there it is, right there. Oh my gosh, guys and gals, check this out. You guys see the tear right there at the top?
Yes, we do.
That tear is, and it's got the inflammation on it. That's the red stuff. This is exactly what causes his back pain. It is that red inflammation right there. So what causes the inflammation? That's his body literally attacking the herniation, trying to get rid of it, the herniation in the tear. And it can't, but this is where all the pain fibers are. So by zapping it with the laser, I get rid of the source of back pain. And we do this for the neck as well, and the thoracic. We're the only facility in the world that does thoracic disc surgery, transforaminal, for thoracic pain. So there's a lot of people out there with thoracic pain. They need this procedure. You're welcome to come here. Now, I want to tell you, before I take your questions, a quick story. It's unfortunate, but there's a company out there that, in my opinion, is quite dishonest with people, and it's called the Cantor Spine Center. Now, in my opinion, the Cantor Spine Center is being dishonest because I know somebody who unfortunately went there for ultrasonic spine surgery. Now, ultrasonic spine surgery is just a gimmick, unfortunately. It's not like laser, which actually works. But in ultrasonic spine surgery, the surgeon is doing exactly the same thing as a microdiscectomy or laminectomy. The ultrasonic probe, all it does is remove bone, and the bone they're taking out is the lamina. They're doing a laminectomy or a partial laminectomy, hemilaminectomy it's called, or hemilaminotomy is another name for it. When you drill a hole in somebody's lamina. But instead of using metal instruments that could potentially grab the nerve root and damage the nerve root, they're using an ultrasonic probe, which does not damage any soft tissues, including nerves. And that's why we use the ultrasonic probe in neurosurgery. We use it around sensitive soft tissues, and it's been used in neurosurgery for many years, but now it's being used as a gimmick in spine surgery, just like robotics is a gimmick. So I don't recommend robotics or ultrasonic. They don't add anything. They're just another way of doing invasive spine surgery that's damaging to the patient and destructive, and will require additional surgery in the future. All right, any questions?
Yes, we have a few questions. This first one is coming from Pawn Lust on YouTube,
What a surprise, Pawn Lust. Welcome back.
asking, does he have a risk of cauda equina? Out of curiosity, have you ever operated on someone with it using your laser?
All right. So Pawn Lust, cauda equina syndrome is basically where your nerve roots are getting crushed. And every single patient we operate on has cauda equina syndrome. So yes, he has it. He has nerve root compression at multiple levels. I've operated on it in about 5,000 patients in my career, 5,000 surgeries. So yes, very common. And the Duke laser disc repair that you're watching is the very best treatment for cauda equina syndrome. There's nothing better. Good question. All right, Henry, speaking of Duke laser disc repair, before we take any other questions, let's show the audience why is it that that inflammation is so painful, and how we use the Duke laser disc repair, the most successful surgery in the world for treating a herniated disc or bulging disc, how we do the laser treatment of the annular tear and granulation tissue to get rid of back pain.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922. Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
You can see from our video that the disc becomes injured through trauma, some type of traumatic event that occurs in the lifetime of the patient, usually a sports injury or a motor vehicle accident like a car accident. And the forces of trauma, they're so powerful, they're so strong, they get transmitted to your spine. And then once they hit your spine, they cause a tear right here, this tear, to happen in the back of the disc, called the posterior annular tear. And that occurs during the whiplash of the accident, for example. Well, once the tear happens, now you have a way for the nuclear material in the center, what we call the jelly, even though it's not like jelly, it's not liquid. You have a way for that stuff to escape through the tear. And anytime you bend and pick something up, normally the wall would keep the jelly in place while the jelly is being compressed while you pick something up, because bending and lifting puts pressure on the disc and it compresses the jelly and the jelly tries to escape, and the wall keeps the jelly in. But when you have a torn wall from trauma, now this jelly pieces start to escape through the tear, they get stuck in the tear, and then they cause back pain. And that's what we're dealing with here, folks. Hey, Henry,
Yes, sir.
will you have Jacob show me the MRIs, cervical and thoracic, on the Russian patient from yesterday, the Russian patient?
Yes, not a problem. I'll text him right now.
I can't mention names, but we have one of our Russian biochemists here who I have to look at his MRI as soon as I'm out. All right? I want to see them.
Copy that.
All right,
we do.
questions?
Yes, we have a couple more questions. The next one is coming from Scott on LinkedIn.
Yes, Scott. I'm happy to have you here from LinkedIn. Thanks. I'm glad we're seeing some LinkedIn viewers coming because
Agreed.
LinkedIn is obviously a respectable platform where people can see live stream. We don't know how to reach more people. We'd love to learn. If somebody knows, they can help us. All right, go ahead, Scott from LinkedIn.
Asking if someone is no longer in constant pain but still has to be careful on lifting or else symptoms can flare up,
Yes.
are they still a candidate?
Yes, 100%, Scott. They're a very good candidate. You don't want that pain coming back, and more importantly, you don't want to live your life afraid of that pain. That fear of pain is called fear avoidance behavior. It's a well-known, well-documented behavioral psychological phenomenon called fear avoidance behavior, and it's basically people get conditioned to avoid activities that bring on a certain response, such as pain. So you're going to have to live your whole life limiting your activities, and your quality of life will be tremendously affected because you're afraid to do anything. It is a horrible way to live. We will fix your back so that pain never comes back again. That is what we want to do, so that you can have a normal life, go out and hike and jog and run and do all the activities you want to do and be pain-free and not worry about the pain ever coming back. Now, it takes this tear right here about a year to fully heal, 1 year, because the disc, many people don't know this, but the disc is what's called avascular, and it's not an entirely true statement because the inside of the disc doesn't have a blood supply. It's avascular, no blood vessels, but the annulus, the outer half of the annulus does. So the inner half of the annulus does not have a blood supply. The outer half does, but the outer half has to heal the whole annulus through a process called diffusion. And diffusion of nutrients takes a very long time to occur, a very long time. So if your disc is trying to heal and it only gets a little bit of nutrients at a time, it's not going to heal quickly. That's the magic of our circulatory system, is that it delivers nutrients, energy, metabolites, vitamins, micronutrients, so that our body can heal. And the tissues that have the most circulation heal the fastest, like the heart or the brain, kidney. All right, but the healing they have is called scar tissue, unfortunately. And that scar tissue is made up of collagen and elastin and fibrin. All right, any other questions? We're just about done with this first disc. We've cleaned out the tear. And if you look here, you'll see that laser fiber, by the way, is 1 millimeter wide. The glass part, 1 millimeter. So the tear that's left is about 4 millimeters. It's going to take about 9 months for that to heal. All right, any questions? We're done with left 3-4.
Yes, next question is coming from Jerome on Facebook.
Hello, Jerome. Welcome.
Asking, where do you conjure up the motivation to continue doing what you do? What drives you to be you? Big fan here.
Jerome, I appreciate it. You're a good man. I appreciate it. I'll be honest with you, Jerome. Ever since I was a little kid, I would see people in wheelchairs or with crutches, and I always felt massively sorry for them. And I just felt horrible for people like, I didn't know what they had at the time, like cerebral palsy or spina bifida or some kind of problem that kept them from having a normal active life. And I was very active as a kid. I played basketball and volleyball, soccer, all that. And so I felt horrible for these people that I saw that were basically stricken with pain or neurological things that kept them from having a normal life. And I just kind of grew up with that sentiment my entire life. And when I went to medicine, I wanted to help people that other doctors couldn't help. Like, what's the point of doing something everyone else can do, right? So I focused on pain and getting rid of pain. And here I am, and honestly, God has led me here and given me the ability to help people this way. I would never have expected to be doing this ever. I mean, even when I was a neurosurgeon, I finished my training, I didn't expect to be here today. But this is the path that I was given, and I never said no to helping people. And I love getting people out of pain and getting their life back. So that's what drives me. I've got a great family, very supportive. I have been blessed, and I believe I'm doing what honestly is you may or may not believe this, but I believe I'm doing what God wants me to do. So helping people. Yeah, I mean, I can't see myself doing anything else. And, being able to do something no one else can do to help people get better. I mean, what more could you ask for, right? That's like the greatest gift in life. It's better than anything else. I mean, of course, having healthy kids is important to me, and I have healthy kids. But next to that, this is the greatest thing, is to be able to make other people healthy, and have a normal life. So that's what drives me. All right, we're entering, thanks for asking. We're entering the tear at L4-5 on the left. Remember, 4-5 had big herniations and tears on both sides, so we got to do both sides. But right now we're on the left, and we tested this disc, and I was surprised. Remember, we tested the one above, it was 10 out of 10 pain, and then the one below was 10 out of 10 pain, and this one was 8 out of 10, but I think I know why. I think the reason why was when I put the dye in, I think some of it went out the other needle, so it never really built up the pressure up to a 10, like the other two. That's my theory. All right, any other questions?
Yes, we have a question and a comment. For a question coming from Scott, once more on LinkedIn.
All right, Scott, thanks.
Asking, can you see AI helping your practice in the future?
Oh yeah, for sure. Yeah, AI could definitely help our practice in many ways. One of the ways is the biggest problem we have is getting the word out to the world that we can cure back pain now. Because every other doctor, every other therapist, every other chiropractor, they all will tell you back pain cannot be cured. And that's what I was taught, when I was training. And I went to the top neurosurgery training program in the world at University of Florida in Gainesville. I came from Los Angeles, USC. I was the #1 draft pick in the whole country for neurosurgery that year. I was the top applicant. I graduated valedictorian of my medical school at USC in Los Angeles. And frankly, everybody wanted me to come to their residency. Most neurosurgery residencies take only one or two medical students a year into the residency. My year they took 2. Of course, University of Florida was a big program, so you got 2 residents. My co-resident was Paul Tolentino from Harvard. Paul did Harvard undergrad and Harvard med school, and then he came to UF because it was the top neurosurgery program in the world. So he and I both matriculated together in '97, and I got trained by the best neurosurgeons in the world. And then I just met my wife, and we decided to stay in Florida and stay here. And that's where I started, by a series of just, I would call, fortunate events. I came into endoscopic surgery. I learned from the Koreans, the best Korean neurosurgeon in the world, Dr. Sang-Ho Lee. He founded the Woodidal Hospital system in South Korea. There's like 7 or 8 hospitals now. He was the chairman and founder, but he also pioneered the cervical endoscopic transdiscal approach that I learned directly from him. And then I learned endoscopic transforaminal surgery you're watching right now from a variety of surgeons, because cervical spine surgery is much more risky and complicated, and really it's the realm of neurosurgeons, whereas lumbar spine surgery, you have orthopedic surgeons competing and pain management doctors. So I learned from the very best, but the problem is I literally pioneered all these treatments, so I'm the first to do them, and nobody knows about them. And so can AI help me? Many ways. One of the ways AI will help me is I'm actually patenting an AI algorithm for diagnosing back and neck pain right now. It's actually submitted already for patenting. And I have a preliminary patent into the patent office, and I have to modify it for final patent, but it's an AI algorithm that I developed for diagnosing back and neck pain. It's first of its kind in the world. And then I also have four other patents that two for the Duke plasma rhizotomies, and one for the Duke piriformis release, and one for our probe that I designed. So getting the word out that we now have a cure for back and neck pain is very hard to do, because there's so much noise out there, and there's all these million providers in the United States saying back pain can't be cured. Just take pills or do shots or do stimulators or do laminectomy or discectomy, but we're never going to be able to cure your back pain. But that's not true anymore. We can cure their back pain. The problem is I'm the only one. And so those other doctors that don't even know we exist, they're not going to refer their patient here because they don't even know we exist. So getting the word out with AI, I think, is probably one of the best ways to do it. And then, of course, AI for helping me diagnose people's back pain. Once we get the word out and we have, let's say, hundreds of thousands of visitors to our website, I will have an AI chatbot with an AI algorithm for diagnosing neck and back pain that will interact with all of our users, and they'll be able to get a diagnosis from basically my diagnostic algorithms that I created. So that's another way we're going to use AI. But another is education, like online. I want an AI chatbot that will educate the visitors about back and neck pain. And I've already started developing it. It's going to be what's called a metahuman, or a digital human that's very human realistic, that will speak 40 different languages and be able to talk to people on their phone and basically navigate that user through a series of media that help the user understand the source of their pain and educate them so that they understand, number one, what's causing their pain, but number two, what treatments would fix it. So yes, I think there's tremendous opportunity for AI in diagnosing and educating patients on spine conditions and treatments, at least at Duke Spine. And then also with respect to search, and I guess that goes along with education. Great question. All right, we are now at L4-5 on the left, and I am zapping away the herniation right there. You see that? See that little piece of thing right there at the tip?
Yes, we do.
That's a piece of herniation. And right above it is a layer of annulus, okay? The annulus is smooth. It's collagen-like, and you can see there's annulus and then there's herniation stuck in there. So that's what causes the inflammation and the pain. And I have to clean this herniation out of here. It's called a debridement. We published this for the first time about 14 or 15 years ago. The first in the world to do the annular debridement and publish it. And People say, Dr. Duke, why do you need the laser? Well, this is why. The laser is extremely precise. I can zap away tissue at 0.05 millimeters, which is 1 millimeter divided by 20. That's how precise it is. And when you're working next to nerves and next to the spinal cord, it's important to be very precise. This laser is far more precise than any other surgical instrument in the world. There is no surgical instrument that is more precise. Now, somebody may say nanobots. What about nanobots, right? Of course, nanobots are not included, but if you consider nanobot in medicine to be a surgical thing, then I guess nanobots may have us beat. But the laser can remove tissues that are 0.05 millimeters thick. All right, any other questions?
Yes, we have a couple more questions, and we have a comment coming from Bonlust once more on YouTube, following up on their cauda equina questions, saying, "Oh, I thought cauda equina was only with losing bladder function."
No, cauda equina is not with only losing bladder function. Cauda equina syndrome is when you have dysfunction of nerves, the nerve roots in the legs. And it can be motor, sensory, bladder, bowel, but it does not have to include bladder. If you let it go too long without treatment, eventually you will get bladder dysfunction. But cauda equina does not require loss of bladder control.
Next.
That's like saying spinal cord injury means you can't move your arms or legs. No, spinal cord injury could be damage to the spinal cord to the point that you can still move your arms and legs, but not normally. So you have weakness, spasticity, all right, but doesn't mean you can't move at all. So yeah, you misunderstood what cauda equina syndrome is, but that's okay. I don't think you're a neurosurgeon, so I can't hold it against you. All right, any other questions?
Yes, we have a couple more questions. Next one coming from Lanu on YouTube,
Lanu, welcome.
asking a parking question. I notice most employees park their car on the side or back of the building. Why the front has so many wheelchaired reserved? Maybe the state assigned those parking spots?
Lanu, you're funny. So yes, you are correct. So the reason we put the handicap parking near the front of the building is so that the patients have the fastest, shortest access to our building. We want to help the handicapped people get inside quickly and safely. So we have the handicap parking spaces close to the entrance. And then everybody else, I tell my employees they have to park in the back so that our patients can have easier access to the front. It's basically just trying to help the patients get in, get parking easier and get in easier. So, no, it has nothing to do with the city. The city, it's not a gentleman. It's I think it's a female. I could be wrong. Yeah, it doesn't have anything to do with the city. The city has a specific number of handicap parking that we have to have. So we're required to have a certain number of handicap parking based on total parking spaces, based on the fact we're a medical facility, and based on square footage. But where we put the parking spaces is up to us, and we always want to try to serve our patients as best we can. All right, we're just about finished with this L4-5 on the left, correct, Luis?
Yes, sir.
And we're going to move on to the next disc. Again, a very big tear, and we just clean it up. A lot of patients we treat have smaller tears, but this patient has really big tears. By the way, he's from Canada, and I can't tell you anything more just because I'm protecting his information. But that said, big tear. It's been cleaned now, so it'll heal properly. There's the epidural space and a little bit of still inflamed fat and fascia, but we're pretty much done here with this side. Great questions, by the way.
We have a couple more questions.
Yep.
These next two are coming from Sujoy on YouTube.
Hello, Sujoy. Welcome.
First,
I think that's our first Sujoy question, right?
I believe so. First question they asked is, hi, Dr. Duke.
Hi, Sujoy.
How will you determine needle entry point?
Ah, Sujoy. You sound like a surgeon. I wonder if Sujoy is a Korean surgeon.
That's a good question. Maybe
Let's
we'll
see
see
what
what they
Sujoy
say.
says.
Yeah.
Sujoy sounds like a Korean name, but I could be wrong. Well, it's a great question, Sujoy. It's one of the special techniques of mine, and I used to, when I first learned to do this surgery about 20 years ago now, I did measurements. You know, I put the metal bar across here, I put it here, and I looked at the angle of the disc and the entry point. And I did that for the first maybe 5 years. And then I just realized that I realized the anatomy kind of teaches you where you're supposed to go. And there's special consideration about the entry point. But you're right, there's an entry point and then there's a target, an entry and a target. And that's really the two most important points, your starting point on the skin and your target in the spine. And the target is always the same. It is as medial as I can get underneath the facet over to the tear. I want to be as medial as possible. So the target is as medial as possible. The starting point is as lateral usually as I can get without risking injuring the patient. So what kind of injury could occur? Well, actually, great question. Okay. There's lots of things here inside that you can't see that I know are there, and I know where they are. The kidneys, for example, when you're a little higher up, you can injure the kidneys. You can injure the intestines. You can injure the ureter. You can injure blood vessels. So the starting point is very important, and it's one of my, something that I've over the years gotten very, very, very good at, doing thousands, well now over 2,600 patients, but we average 2.5 discs per patient. That's the average. So we have 2.5 times 2,600, and that's how many needles I've put in. And so you're right, the starting point and the ending point are very important, and what's in between. I know doctors who tried this and have hurt the patient very badly. They've even killed patients, not my doctors, not here at Duke Spine, but elsewhere, because they don't understand the anatomy. The anatomy is very important. You must have a very, very, very good understanding of human anatomy, where everything is, so you avoid injuring structures. One of the most important structures to avoid injuring is the nerve root. So I do have my little secrets and my little techniques that I've developed over the years, and they are quite good. So we're a little bit off on orbit, but one of the most important things you have to do is make sure the x-ray is true lateral, and true AP, which means you have to adjust the WAG and adjust the orbit of the arm in order to get it lined up perfectly. We're still off on orbit by about 2 degrees. You must understand anatomy very well of the spine. You must understand where it's the other way. You must understand where everything is. And you have to be able to visualize it three-dimensionally using the x-ray. It's better. I'd go a little bit further. I can't tell if we went too far or not. A little bit more. I think we went too far. What? I don't know. What do you think? A little more? No? Too much? Maybe too much then. Yeah. All right. Well, it's close, but we're still off by a degree. maybe a degree and a half. You see it? That's better. That's probably as good as we're going to get it. There is a little bit of scoliosis, so we're not going to have a perfect true lateral because of the scoliosis. Any other questions? And what was the second question from? Was it
From Sujoy.
Sujoy?
Sujoy, second question. Oh, they also said they're from India.
Ah, okay.
And the second question they asked, what's the distance from midline of your needle entry point, and do you measure disc height or superior facet margin in lateral position?
Yeah, great question, Sujoy. You're obviously a surgeon. No, I don't measure any of those consciously. They may be subconscious at this point. But it's a great question, a fair question. And I don't measure any of that. I've just gotten very good at doing this over the years. And I feel very confident and comfortable. But I'll tell you this, it's all about placing the needle properly, Shot. You must have good needle placement. And if you have good needle placement, then you're safe, you're set. The needle placement is everything. And by the way, as a neurosurgeon, we're not taught needle placement. That I had to learn after my neurosurgery training. When I trained with my predecessors, like Dr. Sang-Ho Lee, Dr. Gun Choi, Dr. Anthony Young, Dr. Sebastian Reuten. These are all great pioneers in endoscopic surgery. They taught me how to do these surgeries in terms of the endoscopic part, but not the laser part. The debridement was my creation. That's my contribution for the laser procedures. All right, sorry, Sujoy, I can't give you maybe a more satisfactory answer, but I don't have a more satisfactory answer. But I appreciate you being here and trying to learn. I would say the best thing to do, Sujoy, is to come and train at Duke Spine for a year if you're really interested. All right, this is last disc on the left. This is L3-S1. Once again, Sujoy, there are no surgeons in the world that do transforaminal L3-S1. But I do it. I've been doing it 20 years. I've never had an injury to the nerve, and I think maybe 1 out of 100 patients I can't get here because of anatomical constraints. But I've been very, very successful at treating L3-S1 transforaminal. If you're an endoscopic surgeon in India, you probably were taught this UBE technique, the unilateral biportal, and because that seems to be heavily marketed in India, China, and Korea. I think Koreans are mostly teaching the Indians how to do it UBE. That said, you guys don't do transforaminal 5-1. You guys do interlaminar or translaminar 5-1. And I don't recommend that because it will destabilize the segment. And even in the United States, the spine surgeons, the very few of them, there's less than 10 that do endoscopic surgery, true endoscopic surgery, and those 10 don't do transforaminal 5-1. They don't know how. They can't do it. So they do translaminar or interlaminar 5-1. And they do a lot of translaminar 4-5 and 3-4 as well. All right, good question.
Next question is coming from Scott, once more on LinkedIn,
Sure, Scott.
asking, would a laser with an angle be helpful?
Very good point, Scott. Very, 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 very good point. I love it. Someone's done their homework. So yes, there are 2 types of laser fibers. There's straight and angled. My predecessors, if they ever did use laser to remove a herniation, they would use angled. The problem is, all right, I'm going to tell you my answer and you may not like it, okay? You may not agree with me, and that's fine. So remember, I've been doing this for 19 years, okay? And I'm going to say this. What's our success rate? Why does that matter? Well, our success rate, we eliminate 99.6. Write this down. 99.6% of back pain, discogenic back pain. That's our average, 99.6. Okay? Which rounds up, if you do your math, to 100%. So we are able to get rid of 100% of back pain coming from the disc, the damaged disc, right? In this patient, there's 3 of them. I expect this patient to have 100% back pain relief. Now, we use a straight firing laser. We've been using it. I've been using a straight firing laser since the beginning. I've tried side firing lasers, but I'm not going to tell you why I don't use them, but I will tell you with the straight firing laser, we have a 99.6 or 100% elimination of back pain and basically 100% effective treatment of radiculopathy. That's a different definition, but I won't go into the details. So, or cauda equina if you want. So why do I use a straight firing laser? The answer is, it's very simple. It's not complicated. The answer is because it works. It works. You cannot do better than 100% pain relief. Okay? If I had 80% pain relief, maybe I would consider changing what I'm doing to something else. But when you have 100% back pain relief from this procedure, and it's a straight firing laser, why change the laser? You see the point? Now, there's other reasons too I don't like side firing laser. Number one, side firing laser does not allow you to deliver laser energy straight. It's very easy to see straight, right? You can see what's happening. You see the effect of the laser energy on the tissue. With side firing, it's hard to see sometimes. Now, that's not always true, but in some applications like what I do, it is harder to see with side firing. The second reason is, and this is more of a cost issue, side firing laser fibers are more than $1,000, like $2,000 each, right? Yeah. They're just obscenely priced. So why go from a treatment that has a 100% cure rate of back pain to another procedure with a side firing laser that could only get less than 100 or 100, so it won't be any better than 100, but the cost is going to go up dramatically for the patient. I'm going to have to charge patients a few $1,000s more because of the side firing laser fiber is not reusable. It is not reusable. You can only use it one time. It cannot be autoclaved or processed. So you're basically throwing that money away for no reason. So I don't use side firing laser ever. I don't need it. It's a waste of money. It's just increased the cost for the patient to have to pay, and I don't see any benefit. So there is no cost benefit advantage of using a side firing laser. There's your answer. Thanks for asking. Good question. See the piece of herniation there?
Yes, we do.
Now, why isn't that herniation coming out? The answer is it's scarred down. It's literally stuck to the annulus from all the inflammation that's been going on. Sometimes I have to use the grabber to grab those pieces of herniation and just rip them out. They're faster than the laser, by the way. But sometimes I can't grab them out because they're stuck down too hard from scar tissue, from the inflammation happening. Any more questions?
Yes, we have a couple more questions. These next two are coming from Pawn Lust once more on YouTube.
Did you guys see the inflammatory tissue there to the right?
I believe so. Yes, we did.
Just a quick flash of it, but I'll show you again in a moment. Give me a second. Let me show you the inflammatory tissue, and then I'll take Pawn Lust's question. Remember, we're at L3-S1 left side. We have one more disc to go. It's L4-5 right side. And then we're going to end the stream. We're going to come back and do a piriformis release. This patient also has a torn piriformis muscle. He lives in Canada. It took him a long time to get here because he lives far, far, far in Canada, like far north, I believe. And we don't want to send him home without treating everything that's causing his pain. All right, let's see. There's the inflammatory tissue right there. Go ahead with Pawn Lust's question.
First question from Pawn Lust asking for small cervical central bulges, which other surgeons can't access. Would it be transdiscal?
Yes. Yeah, sir. First of all, what Pond Lust is asking is he's saying, Dr. Duke, I know you fix discs herniations in the neck, right? We call those cervical herniations. Cervical is in the cervical spine, right? The neck. And can you fix a small central herniation transdiscal? The answer is yes, 100%. That is the Duke laser disc repair. What you're watching right now on the lower back, we do on the cervical spine and the neck for herniations. And it is the very best treatment in the world, even for small central disc herniations, because the spinal cord is behind the herniation and we enter from the front. So we have virtually no chance of injuring the spinal cord unless we're totally incompetent, which there are a lot of incompetent surgeons out there, by the way, but not at Duke Spine. By the way, I've received some incredibly good news today. My son, who, if you think I'm smart, he is literally 5 or 10 times smarter than me. He's probably the smartest person I've ever met in my entire life. He's at Princeton, and I think he just got straight A's this semester, taking OChem, Korean, biology, and one other class, I don't even remember. And that kid decided that he's going to become a neurosurgeon, following his father's footsteps. Now I've just got to convince my daughter to do the same. And the good news is that when I die or become incapacitated, he will take over and be able to treat everyone here listening to me. He'll be able to treat your children, all right, your grandchildren. That's the most important thing I could ever ask for. Why? Because I don't trust anyone to do these surgeries. I only trust the very best people, the very best surgeons. And Duke Spine will forever be all about quality care. The very best spine care in the world. That's what I'm creating here at Duke Spine. Now, Dr. Sang-Ho Lee did the same thing in Korea. He created the Woodydal Hospital system for the best spine surgery in the world. But I learned from him, and I took his technique and I made it better. I improved on it. And that's what we do as researchers, doctors, physicians, scientists. We take something that's being done now and we improve on it. We make it better for people. All right, and that's what we've done. We've made surgeries, endoscopic spine surgery, the very best it can be. You understand what I'm saying? The very best it can be. And to be honest with you, what was the U.S. hockey team that won the Olympics against the Russians? Back in 84?
Let me check.
It was the greatest upset in sports history, and I was there watching that game. I think it was 84 or 86 or 87.
Yeah, in 1984 said the Soviet Union won. It's 6 gold medals, so hold on, let me check.
No, this was the U.S. hockey team, the total underdog of the world in hockey, beat the greatest hockey team of all time, the Soviet Union hockey team.
Miracle on Ice. Was
Miracle on Ice.
Yeah, 1980 Winter
80.
Olympics.
All right.
Lake Placid, New York.
Yeah, you like the movie, but watching that game on television in 1980 during the Olympics and watching America beat Russia was the greatest upset of all sports history. There has never been another upset like that. And that is what Duke Spine is. We are that American hockey team going up against the greatest, most powerful hockey teams in the world, like Russia, and defeating them with our technique, our heart, our courage, our just sheer willpower to do the best. That's what Duke Spine is. We're the tiny little company. We're the underdog of all hospital systems, the Mayo Clinics and the Cleveland Clinics and all the big hospitals around the world, the Rothman Orthopedics of the world, the Texas Back Institutes, and the big companies. And we literally come from nowhere, and we're defeating everybody because we're trying to do what's best, you know, and avoid the politics and just play our hearts out. That's what my team does every day here at Duke Spine. And I'm very proud of them. I'm very proud of them. I don't get to say that too often, but it's absolutely true. You guys are a miracle on ice, but we're called the miracle in the OR. You like that? Not the miracle on ice, will be the miracle in the spine. There we go. The next movie, Miracle on the Spine. Miracle on the Spine. You like that, Henry?
I love that title. That works out really well.
Spine. All right. So, any questions? We're just about done. We're going to switch to the other side. We have one more disc to do. We'll end the stream and we'll do the piriformis.
We have about 3 questions. This next one is coming from Pawnlust once more on YouTube, asking, why does microdiscectomy cut bone, but you don't?
That's because microdiscectomy is a bad, old bad surgery. It's the way that surgeons used to get down to the disc. That was the only way they could. It was very hard to do, and the endoscopic surgery is even harder, but it requires training. Pawnlust, I don't know what you do for a job, but I can teach you how to do a microdiscectomy, right? But teaching you how to do endoscopic surgery is much harder than doing a microdiscectomy. And that's why there are very few doctors in the world that do endoscopic surgery, is because it is harder. We all know how to do microdiscectomy, but microdiscectomy is an old technique that's very damaging. Okay? Old technology, very damaging. Someday, people are going to say, why did we ever have power plants that burn coal and pollute the atmosphere, right? With all that toxic smoke from burning coal. Why didn't we always have nuclear power plants? Right? That's what they're going to say. Or why didn't we always have wind or solar? But the answer is that was the best technology we had for a long time, was microdiscectomy. The problem is it's an old technology. It should be put to bed, gotten rid of. It's bad, right? We have much better technology now. So it's just like any other technology in the world. There's advances, right? So Dr. Parvis Kambin realized everybody was doing this, going right down, making a big incision, basically cutting the muscle, cutting the fascia, cutting the bone, cutting the facet, cutting the ligament to get to the herniation. And Dr. Kambin said, what if we came from the side? And that was his contribution. Dr. Parvis Kambin in Pittsburgh, Iranian orthopedic surgeon, was the first to do transforaminal lumbar endoscopic surgery. But he didn't do a very good job at it. He wasn't that good. He had a lot of complications, but over time his technique was improved on by the next generation. And that generation is the one that taught me. That's Dr. Sebastian Royton, Dr. Anthony Young, Dr. Knight out of England, Dr. Seng-Ho Lee. Those guys taught me, and they actually improved on his technique, the technique of Dr. Kambin, who was the inventor of the transforaminal approach. So it's just about technological improvement, that's all. And my treatment is a technologically superior treatment to all of theirs. So it's just the next step in evolution. That's why. But microdiscectomy is bad. Don't do it. Don't do it on your patients if you're a doctor. Don't get it done if you're a patient. Is that old or new?
That's right on.
Good. Thank you. Any other questions?
Yes, we have about 3 more questions. Next one is coming from Sujoy once more on YouTube,
Sean?
asking, what's the relationship of facet inclination with transformational endoscopic spine surgery?
Yeah, there's a relationship. It's called, I need an excuse for not being able to do the surgery. I like this Sujoy guy. But facet inclination has nothing to do with the surgery. I don't even look at facets when I'm planning somebody's surgery. Now, if they have ridiculously big facets, like 4 or 5 times larger than normal, that could be a problem gaining access to the foramen from the back, right? If you do endoscopic transforamental surgery, then you know what I'm talking about. So, but other than that, I don't sit there and look at MRIs and CAT scans ahead of time. I just go and do the surgery. Why? Because I know I can do it, right? I don't sit there and go, let me come up with an excuse not to do your surgery this way. I just do it. And I only 1 in 100 come across a patient with the anatomy I can't get around. Now, that said, I am probably the best in the world at getting into the foramen. I don't think anybody in the world is as good as I am. And I say that not to brag, but I say that because I've literally taken on the hardest foramens to get into with, the most difficult anatomy. But I've managed to do it, and I have some tricks. And if you watch enough of my surgery, you'll see those tricks, okay, if you're paying attention. But that said, I don't worry about facet inclination angles as I plan surgery. I don't worry about the disc inclination angles. I don't worry about the amount of scoliosis or kyphosis or listhesis unless it's a grade 3. I won't do a grade 3. Grade 1 and 2, which is 99% of patients that have spondylolisthesis, I'll do. But grade 3 I won't, because that's just too much, too far. And it's rare, thank God. There aren't a lot of patients with grade 3 or 4. So I don't spend a lot of time worrying about things that I have no control over. I just worry about the things I do have control over. All right. Thank you. We're just about finished. We're on the last disc, and then we're going to do a piriformis release next. Any other questions?
Yes, this next question is coming from Professor on YouTube,
Hello, Professor. Welcome.
asking, hi, Dr. Duke, do you cooperate with anyone using this method in Europe, for example, in Poland?
I'm open to cooperating with any doctor or clinic around the world that is interested in providing this type of surgery to their patients, but I am going to be very picky about who I train. Very picky. I'm only going to train the very best, the very brightest, the very most caring doctors. This has to be doctors that want to basically do the best for the patients, and that's all that matters to them. But they also have to have the means, okay? For example, I'm not going to train a doctor to do the surgery that will not invest the money into buying the best equipment, because you do need the best equipment in order to do the surgery properly for the patient. So if somebody came to me and said, well, I need $10 million to buy all the right equipment, but I only have $1 million, I'm not going to train that person, because they're not going to be able to do this surgery properly on the patients. And I'm not going to be responsible for training somebody that's going to do bad surgery on patients. Does that make sense? So that's very important to me, is that the patients who get this type of surgery from surgeons trained by me get the very best care. So if you're a part of a large system that has the resources, we call it resources nowadays, but the money and the ability to get the best equipment for your patients, then I would consider training you. I don't know if that properly answers the question. But yes, I would love to train people around the world to do the surgery and help more people and get out of pain.
This next question is coming from Pretty Fine on YouTube,
Pretty fine. Welcome to our stream.
saying, hi, Dr. Duke.
Hi there.
Congrats to your son, and much love and many blessings to you and your family.
Thank you.
My question is, what happens to the nucleus pulposus before, during, and after the disc repair, and while healing?
That's a great question. So you're interested in learning more about the nucleus pulposus. So I'll tell you a little bit about the nucleus pulposus. First of all, the nucleus pulposus is probably the most misunderstood structural aspect of a disc. Everybody thinks you need nucleus pulposus to be normal. The truth is, 100% you don't need any nucleus pulposus to have a normal back. Okay? You don't. And I don't make this stuff up. If you look at people that are 60 years old, that are out there windsurfing, water skiing, mountain biking, like you go to Italy, right? There's all these little Italian men biking around the whole day for hours on their bicycles, biking up mountains. And like I went to Italy and I'm pretty fit, and I practice my bicycle with my wife, and these guys literally fly past you going up the hill like 5 or 10 miles an hour faster than me. And they're little old men, right? From Italy. And they have no back pain, but guess what? They have no nucleus pulposus left. It's gone. They have complete collapse of their discs. So nucleus pulposus itself is not necessary for any disc to function normally. Okay? It is not. It is a myth. It is a lie. It is really just big business lying to the consumer to get you guys to buy things to put inside the disc, to replace the nucleus that's no longer there. So I caution you and everyone else out there, avoid and stay away from nucleus replacement or new cages or new discs. You don't need them. You don't need them. You're going to have a normal life without back pain, without leg pain, without any symptoms if you have this surgery and there's no nucleus left, even at the end of the surgery. I can have 1% nucleus left in the patient and they have 0 symptoms. Okay? So nucleus is not necessary, period, for having a normal back with no symptoms and doing all kinds of activities you want to do without any pain. That's the first thing you have to accept and understand. Now, I used to believe, just like you, you have to restore the disc height, restore the alignment. You have to put some type of biomechanical device or gel or something in there that's going to give back the cushion, okay? But what I've learned from treating patients for years and years and years is that there's 90% of the population over 60 has no nucleus and they have no symptoms. So why is that? The answer is you don't need the nucleus, period. Okay? It's not something I made up, it's something I observed. So what is the nucleus? The nucleus truly is, this is what I discovered, by the way, and this is important if you're interested in the nucleus. I did not discover what the nucleus was. I read about it, I studied it in medical school. The nucleus pulposus is the remnant of the notochord. That's spelled N-O-T-O-C-O-R-D or C-H-O-R-D. I can't remember which it is, but notochord. The notochord is an embryological tissue found in the embryo within the uterus. It's a developing human being. And the notochord basically instructs primitive germ cell tissue to become muscle and bone and nervous tissue, intestinal tissue. It basically directs what's called the differentiation and multiplication of germ cells to form what are the adult primary tissues made up of ectoderm, mesoderm, and endoderm. That's your skin, your muscles, your bones, and everything inside, and your integumentary system. So all your adult tissues are basically differentiated from germ cells into those tissues at the control and oversight of the notochord. So when the notochord's job is done and it is no longer needed in the fetus, it cuts itself up into little hamburgers, little pepperoni pieces, and it goes into the middle of the disc and it becomes encapsulated, surrounded by collagen, which becomes the annulus fibrosus, right? And the annulus is really collagen and elastin, but primarily collagen. So the nucleus pulposus is truly a remnant of the notochord, and everybody thinks it's a cushion, but it's not. I think it's hidden, and here's my discovery for medicine. The notochord and the nucleus are the same, but it's inside the middle of your disc to be hidden from your inflammatory system, because it is so inflammatory that it has to be hidden away from the inflammatory system in the adult Otherwise, you'll be in constant pain. So when you get a tear in your wall of your disc, an annular tear, and the nuclear material squeezes out, it creates a massive inflammatory response that causes horrible back pain and leg pain. And that is your sciatica and your cauda equina and your back pain, discogenic back pain. Henry, let's end the stream on our how does a disc injury cause back pain? And any additional questions I'll take in the next stream. We'll be back because we're basically done repairing this disc. We'll be back with our piriformis release next. Thanks for joining.
Disc injuries start with an annular tear. Damaged nucleus. Pulposus herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 34